Good afternoon, ladies and gentlemen. Before starting, I would like to thank all the members of the EpicLatino team for giving me the opportunity to participate in this virtual congress and to present some conferences. And I also wanted to express my gratitude to Paulina and the whole team that helped me making this virtual presentation possible. Today we're going to talk about the management of anemia of premature infants and especially when to transfuse and other controversies. Transfusions of red blood cells are one of the most common interventions in the management of neonates, and from the beginning of neonatology, specialists have noticed that smaller and most premature babies only survived if they could receive a red blood cell transfusion. We have progressed significantly since those first days of neonatology to today with blood banks where we process thousands of units of red blood cells for transfusions every day. In this study by Dr. Jack Woodness in the University of Iowa that has not been published from 2000 to 2005, he examined the percentage of babies that received red blood cell transfusions here in the circles and platelet transfusions depending on the weight at birth. And as you can see here, approximately 3% of the newborns over 2.5 kilos at birth received at least one transfusion of red blood cells. This percentage increased to 9.5% in the smallest babies of 1.5 to 2.5 kilos at birth, and to 43% of babies between 1 and 1.5 kilos, and almost to 90% in those below 1 kilo at birth. If we multiply these percentages and the number of transfusions that these patients received by the number of live births in the United States in 2006, we see that annually in the United States, and this is almost 15 years ago, a total of 280,000 transfusions were administered a year to patients in NICU, and most of these transfusions were for extremely low weight babies below 1 kilo. Why do we transfuse our patients? The main reason for which neonatologists decide to administer a transfusion to a newborn baby is to increase hemoglobin, because we recognize the importance of hemoglobin to make sure that there is an adequate availability of oxygen to the tissues. As we all know, hemoglobin is part of the equation that determines the availability of tissue oxygen, and that includes the cardiac output. So the most important reason is to be able to have a hemoglobin level that will ensure that the tissues and the organs are receiving enough oxygen. The problem is that we do not know how much hemoglobin a patient requires in order to ensure an adequate tissue oxygenation. 20 grams per deciliter, 17, 14, 10, maybe 7 grams per deciliter is enough hemoglobin. And we also have to remember, as neonatologists, that unlike adults where the availability of oxygen has to simply ensure the basal maintenance and basal functioning of all our organs and tissues, in neonates, it also has to allow and promote the rapid growth of organs, especially of the brain. As you can see in this chart, the brain grows and increases its weight a total of 275% during the first year of life, in comparison to 21% throughout the rest of the life after the age of 2. This is an adult. So this means that we not only have to ensure the flow of nutrients and oxygen to maintain basal functioning, but to also allow the growth of all the organs, and very importantly, the extraordinarily rapid growth of the brain during the first year of life and during the last hours of gestation. Surprisingly, in spite of the frequency with which we provide blood transfusions to neonates, The first randomized studies trying to compare restrictive and liberal levels of transfusion were not published until 2005 and 2006. In 2005, the first study in a single institution, the University of Iowa, by Dr. Bell, including 100 patients, was published. In 2006, a year later, Dr. Kirpalani included the results of the first multicentric study, PINT, which included several intensive care units in Canada and the United States and included 461 patients. Both studies compared transfusional, liberal, and restrictive strategies in neonates below 1,500 grams, and in both studies, the levels of hematocrit used as limits were adjusted according to the respiratory support of the patient. However, there were some differences. In this table, I show you the level of hematocrit used in both studies, in the liberal group and in the restrictive group, in patients with respiratory support and in patients without respiratory support. Unlike PINT, that reduced the levels of hematocrit as the postnatal age increased in all the groups, the Iowa study maintained the same levels throughout all the groups regardless of the postnatal age, and specifically maintained very high levels throughout the whole period in intensive care units in patients assigned to the liberal group that were receiving invasive respiratory support. In other words, they were on a ventilator, and also relatively high numbers in those that received non-invasive respiratory support. Both studies initially published the results at a short term, so at the time of releasing the patient from NICU. The Iowa study found that the patients assigned to the restrictive study were less transfused, which was not a surprise, but they had a higher incidence of apnea and abnormalities in the brain ultrasound, which means that using restrictive parameters can have negative effects on the development of the brain. A year later, in 2006, the PINT study published its short-term results. They also found less transfusions in the restrictive group, but they did not find any difference in any of the parameters studied between the groups, including no differences in brain ultrasound abnormalities. The PINT study was criticized back then, however, because the separation of levels of hemoglobin between the liberal and the restrictive group was very small, only of approximately 1 gram per deciliter. In 2009, Robin White and collaborators published the long-term results of the patients enrolled in PINT. This study consisted of psychomotor follow-up to 18 to 24 months of the babies that had been randomized during their admission in the NICU. And over 90% of the patients participated in this follow-up. The primary result was a mixed result of death and a combination of neurological deficits, very significant. This primary result did not show any significant differences between both groups, restrictive and liberal. However, in an ad hoc analysis, the researchers found a higher incidence of cognitive impairment in the group with restrictive controls and transfusions versus those with the liberal ones. Approximately 45% of the infants in the restrictive group with a mental development index below 85 compared to only 33% of the patients in the liberal group. This suggested once again that the assignment of neonates to more restrictive transfusions could result in more long-term neurological impairments. In 2012, the Iowa group published the results of the long-term neurocognitive study of the patients that had been enrolled in that first study. This study was different from the long-term follow-up of PINT. in which only 56 of the 100 infants in the original study were evaluated. So, in other words, a much lower retention rate. And second, that these patients were evaluated during school age, between 8 and 15 years of age, with a mean of 12 years. Very different from the 2 years of age at which the pint group was evaluated. Of these 56 patients, 23 belonged to the restrictive group and 33 to the liberal group. And they all received tests for cognitive functioning, memory, verbal association, motor coordination, visual, motor integration, visual spatial reasoning, and even the reading skill. Surprisingly, in all the intelligence tests, the children in the liberal group that are shown here in the white bars obtained lower points than the babies in the restrictive group, shown in the gray bars. And these differences were significant in verbal fluency, visual memory, and reading. That same year, the same group also published a neuroradiological result of the same groups that included 44 of the 100 original infants that were evaluated with MRI at a mean age of 12, compared to healthy controls born at term. This group, evaluated radiologically, included 18 children that during the neonatal phase had been assigned to the restrictive group, 26 that had been assigned to the liberal group, and 40 controls. Once again, the liberally transfused children had an intracranial volume that is significantly lower than the controls. And not only that, but they also found a significant effect of sex in the cerebral structures, with the girls transfused liberally with a higher or a more marked reduction in intracranial volume measures. As you can see here, the girls are in gray bars and the boys in the black bars. In many of these measurements of intracranial volume, the girls in the liberal group had the highest reduction in all these measures for brain development in comparison to the randomized boys in the liberal group. Obviously, these highly contradictory results in the long-term follow-up left the scientific community and the neonatologists with an enormous amount of discrepancies and ambiguity. How can we explain these discrepancies with PINT suggesting that the restrictive strategies result in greater cerebral damage, while Iowa is saying that it doesn't? So an alternative indicates that tests at 18 months does not predict neurocognitive development adequately at 12 years of age, and this is still to be studied. Secondly, many researchers suggested that the results of Iowa are not representative because of the low percentage of patients that were studied in the follow-up. And finally, is it possible that severe anemia and the excess of transfusions are associated to an abnormal psychomotor development and are negative for babies? And in this sense, if we compare the average hematocrits of the babies associated to the restrictive group in Iowa and PINT studies, they were both relatively similar. But if we compare the average hematocrit of babies that were assigned to the liberal group in Iowa with PINT, we see that those in Iowa assigned to liberal transfusions had a much higher hematocrit than those assigned to the PINT group. And in fact, if we look at this data, the patients assigned to restrictive transfusions and to liberal transfusions in PINT and those assigned to the restrictive group in Iowa are very similar. The two that had the best long-term neurological development. Obviously, with these differences in the results in these studies, The transfusions and transfusional practices were highly variable in the following years, and they continue to be in different units with different neonatologists and in different countries. In 2012, the neonatologists from 22 countries were surveyed, receiving over 1,000 answers from 11 countries, 67% from the United States. Approximately half of the intensive care units that were studied reported to have transfusional guidelines, and the most important factors in the decisions for transfusions, as we all know, were the level of oxygen at the moment, the level of respiratory support, postnatal age, and the percentage of reticulocytes. In this chart, I show you the variability in levels of hemoglobin to which neonatologists that were surveyed said that they would administer a transfusion. First of all, there was a variability depending on the postnatal age. This is first week, second, third, and fourth weeks. And also depending on the level of respiratory support at the time of obtaining that hemoglobin. But in each one of these groups, there was at least a variability of 2 grams per deciliter in the levels of hemoglobin at which neonatologists transfused. For those of us that follow literature in this area, throughout this whole time, we were waiting for the results of 2 studies that were being conducted almost in parallel in the United States and Europe. The first is TOP study, or Transfusion of Prematures trial, which is a randomized study in the United States sponsored by the National Health Institute, and the second was ETNO, or Effects of Transfusion Thresholds on Neurocognitive Outcome of Extremely Low Birth Weight Infant study, which was a European study that started in Germany. Fortunately for us, in August 2020, approximately 2 weeks ago, the results of ETNO's study were published. ETNO was a randomized study that also compared restrictive red blood cell transfusions versus liberal in extremely low weight neonates. This was done in 36 NICUs in Europe, most of them were in Germany, and this table shows the hematocrits below which transfusions were provided in the liberal and the restrictive groups. As you can see, the levels at which the transfusions were administered varied depending on whether the baby was in a critical or non-critical stage, and also depending on the postnatal age. In total, ETNO randomized 1,013 neonates, 492 to the liberal group and 521 to the restrictive group. 450 of these 492 had the primary result, and 478 of the restrictive group completed the whole follow-up for the primary result. The mean gestational age of the babies in ETNO was 26 weeks in both groups, and the weight at birth was approximately 750 grams, with a very well-balanced distribution by the original design of the study between the babies with birth weight below 750 grams or above 750 grams. In general, the babies assigned to the liberal group, 81.3% received a transfusion, and the mean volume of red blood cells transfused throughout the whole stay in NICU was 40 milliliters in this group. In comparison, in the restrictive group, only 60.5% of the newborns were transfused, and the mean volume of transfusion that the babies received was 19 milliliters. And in this chart, you can see the average hematocrit on a weekly basis that the babies had that were assigned to the liberal group, that is here in blue, and the restrictive group that is shown in orange. As you can see, as the stay in the NICU advanced, the separation was greater, and it reached an average of approximately 3% between one group and the other. As to the primary result of ETNO, it was a composed result of death or neurological or cognitive impairment at 24 months of age. As you can see here, there were no significant differences between the liberal and the restrictive groups in this primary result, nor in any of the components of the result. There was no difference in death, there was no difference in cognitive deficit, nor any difference in the incidence of cerebral palsy at 24 months. In the same manuscript, the authors also presented the short-term results, so in other words, at the time of release. And as you can see on this table, there were no differences either in any of the parameters that were studied during the admission. In the incidence of intraventricular hemorrhage, preventricular leukomalacia, pulmonary dysplasia, retinopathy, or presence of other illnesses, there were no significant differences in any of the cases between the liberal and the restrictive groups. So what happens with TOP? Both studies were advancing almost simultaneously. TOP is the transfusion of prematures trial. It's the randomized study parallel to ETNO that was being conducted in the United States. The design is very similar to ETNO, and although results have not been published and therefore I cannot present the specific information to you, they were presented virtually in the Congress of the American Pediatrics Association approximately 4 weeks ago this year. And I can say that there were no differences either between both groups of restrictive and liberal transfusions, neither at the time of the release or follow-up for 24 months. The publication is imminent, however, we already know the results, and therefore we can conclude that in the most recent randomized studies, a liberal strategy for the transfusion of red blood cells did not reduce the possibility or potential for death or disability or impairment at 24 months with extremely low birth weight. So the current combination should probably be to use restrictive limits, but within the parameters studied in TOP or ETNO. However, it is important to acknowledge that we have still not eliminated the possibility that there may be differences between the restrictive group and the liberal group if we examine this at a longer term. And precisely to try to answer this question of what the effects of anemia are on the brain and on cerebral development of a premature neonate, Dr. Juan developed a model with mice for neonatal anemia induced by phlebotomies, very similar to what we do in intensive care units with our neonates, in which we induce hemorrhage in the laboratory. In this model, neonate mice, starting from the 3rd day of birth, were subjected to phlebotomies twice a day, which resulted in a progressive reduction of hematocrit up to approximately 23-24%. Very similar to the process and the end results that we reach in our premature babies. Once this level was reached at around day 7 or 8 of life, a daily phlebotomy was carried out to maintain the hematocrit at the stable level up to day 14, when the animals were sacrificed to examine the brain. The important thing about this model is that the brain of a newborn mouse on day 3 is equivalent to the cerebral development of a human baby of 26 days of gestation, and on day 14, it's equivalent to a baby at term. So this gives us the opportunity to investigate at a cerebral level what the effects of anemia are on an animal model during this phase of development. The first important discovery of this model was that anemia induced by phlebotomy induced a reduction in the concentration of iron throughout the brain that was very significant in comparison to the controls, to the animals that had not been subjected to phlebotomy. and very similar to what had been studied for a long time already in models on iron deficiency induced by diet because of a lack of administration of iron. So in other words, phlebotomy. Anemia induced by phlebotomy is associated to an important reduction of the concentration of iron at a cerebral level. And not only this, but also in a spectroscopy test by magnetic resonance, researchers found a series of peaks that revealed metabolic abnormalities. But very important was a peak in lactate that suggests cerebral hypoxia. These mice looked completely normal. They eat, they're active, they grow, they gain weight. They do not have an elevation in lactic acid in the blood, but they have evidence of hypoxia and iron deficiency at a brain level, therefore indicating that there are significant consequences in the brain that cannot be detected from a clinical point of view. In conclusion, to now, by human studies, we know that the use of restrictive strategies for red blood cell transfusions in premature neonates does not increase neonatal mortality, nor is it associated to neurological deficiencies that are detectable at 24 months. However, we know by preclinical trials, as what I've just shown you in animals, that anemia induced by phlebotomy affects the metabolism and cerebral development by two mechanisms, by hypoxia and also by iron deficiency. And by a large number of studies in humans, we know that the anemia by iron deficiency during infancy is not associated to massive neurological deficits or cerebral palsy or death or blindness or deficits detectable at 2 years of age. But it is rather associated to deficits of memory, learning, behavior that is generally detected later in life. So here we only have a few examples on some of these studies for long-term follow-up that have demonstrated that iron deficiency in infancy, although it is later corrected, is associated to impairments in memory, cognitive impairments as age advances, and also in behavior in teenagers. In this sense, top study is following up to a school age of the randomized patients at liberal or restrictive levels during their stay in the NICU, and therefore will have a more long-term response in the coming years. Current recommendations are probably to use restrictive strategies within the limits studied in TOP and ETNO with the evidence that we have. However, it is important to also use strategies that will allow us to maintain the better hematocrit possible in these neonates without having to increase transfusions. First of all, it is important to implement the transfusional guidelines in all our units to place a lot of attention on iron to avoid the deficiency of iron, the late clamping of the cord when possible, and to avoid as much as possible hemorrhage in the lab using techniques to try to use the lowest blood volumes as possible. And also the use of erythropoietin has been suggested to keep a high level of hemoglobin or hematocrit to avoid many transfusions. In that sense, on August 17th this year, this study was published by Dr. Jewell looking at the effect of the high doses of erythropoietin in blood transfusions in neonates. So this was a post hoc analysis of the PEANUT study, which was a study for the administration of erythropoietin for neuroprotection based on a large amount of evidence indicating that erythropoietin could be a protecting factor. This is with neonates from 24 to 27 weeks, and they were randomized to receive erythropoietin erythropoietin or placebo, 1,000 units per kilogram of placebo every 48 hours for 6 doses, followed by 400 units per kilogram three times a week until 32 weeks of gestation. In total, 941 neonates were randomized. 477 were randomized to receive erythropoietin, and 464 were randomized to receive placebo. And as you can see here, the babies that were randomized to receive placebo, which are in blue, had a higher percentage of transfusions during the weeks of study in comparison to the babies randomized to receive erythropoietin that had a lower potential for transfusions throughout the study, especially during the intermediate period. In total, of the patients randomized to receive erythropoietin, 24% did not receive any transfusions in comparison to 9.3% of those that received placebo. The number of transfusions was 3.5 in the erythropoietin group compared to 5.2 in those that received placebo. The cumulative volume of transfusions was 47 milliliters in the EPO group in comparison to 76 milliliters in the placebo group. And the exposure to donuts was also lower, 1.6 in EPO group in comparison to 2.4 with placebo. So in other words, there is no doubt that erythropoietin in this regime, in this population, reduced the number of transfusions, and the babies maintained a similar or better hematocrit than those assigned to receive placebo. However, the primary objective of Peanut study was to examine the neurocognitive development and mortality, and the primary result was also a mixed result of death or deficit of cerebral development, such as cerebral palsy. So in this sense, in a publication in the New England Journal that was published January this year, they did not find any significant differences between the group assigned to erythropoietin and the group assigned to placebo in terms of the primary result and all the components within this primary result. The authors hypothesized in their latest manuscript that this could be due to the fact that erythropoietin increased hemoglobin and hematocrit, and therefore it reduced the number of transfusions and the anemia. But babies treated with erythropoietin had a tendency to have a higher iron deficiency based on the iron tests that they performed as part of the study, in comparison to the babies that received placebo. So in other words, suggesting that maybe erythropoietin increased erythropoiesis and increased the level of red blood cells, hematocrit, and hemoglobin, but sacrificing the reserves of iron, therefore affecting the brain in these two different directions. And precisely to answer this question, if this is possible, Dr. Georgiev used the same model of anemia induced by neonatal phlebotomy that I already described, with which he induced a hematocrit of 22% in the phlebotomized neonate mice, and he treated a group of mice with erythropoietin to try to rescue or to save this anemia, to induce anemia and to treat with erythropoietin, with which he obtained a better hematocrit of 27%. Then they examined the brain of these animals to see the levels of a marker of the state of the concentration of iron. An increase in the levels of RNA indicates an iron deficiency, and they used the growth factor of vascular endothelium as a marker of hypoxia in the brain. An elevation in VEGF values indicates cerebral hypoxia. As you can see here, the randomized mice that were subjected to anemia induced by phlebotomy had an elevation in the transferrin receptor, and those treated with erythropoietin did not improve in this parameter, indicating that the iron deficit was probably similar. While the mice treated with erythropoietin and subjected to anemia by phlebotomy had a reduction in the vascular endothelial growth rate, suggesting a possible partial improvement in regards to hypoxia, cerebral hypoxia. Therefore, it is very important that aside from the hematocrit, to make sure that we maintain an adequate level of iron to supply the brain with the need of these essential nutrients. And well, with this, I thank you very much for your attention, and I'm at your service to answer any question. Thank you very much.